Thank you so much for inviting me to talk today. I'm going to be talking about our COVID-19 vaccines with a particular focus on how we can update the vaccines and what we've learned about them. So I've been a clinical investigator for clinical trials that are funded by various different sponsors, but I do not have any financial interest in any of these companies. In the last 3 years, over 13 billion COVID-19 vaccines have been given. This is a picture that just shows the share of people around the world who've received at least one dose of a COVID-19 vaccine. And in the Americas, Europe, big parts of Asia, a lot of people have gotten one dose of a vaccine, but there's still a very large fraction of people around the world who haven't actually even received a single vaccine. So I always want to lead with that because the rest of our discussion, we're talking about boosters and updated boosters, but just don't forget, there's a lot of people who've never been vaccinated at all. Also, COVID-19 vaccines, the type of vaccine varies really significantly around the world, and mRNA is not everywhere. This is again to frame our discussion because the updated vaccines are mRNA-based vaccines. But this is a graph of some data I pulled that just shows the type of vaccines administered in a couple example countries. So in the US and the European Union, more than 1.5 billion vaccine doses, almost all of it mRNA. South Africa, far fewer doses administered. What they've given is mRNA and the Ad26 based vaccine. And then in India, though, you'll see it's more than 2 billion vaccines that have been administered, and really none of them have been mRNA. Almost all of them have been adenovirus vectored vaccines. Nevertheless, in that first year of giving out these vaccines, they're estimated to have prevented 14 to 20 million deaths globally in that first year. The figure on the left is showing the deaths averted by vaccinations per day over time, according to whether your country is considered high income, upper middle income, low income, as defined by the World Bank. And most of these averted deaths really occurred in high income and upper middle income countries. And that's shown on the right as well. And I just wanted to highlight the difference in the estimated deaths averted by vaccinations. 62 deaths per 10,000 people in the European region. In contrast, only 4 deaths averted per 10,000 people in the African region. And this reflects that distribution of vaccines that I talked about. So as these COVID-19 vaccines have rolled out, they have been not just a challenge of distribution, but also a challenge of SARS-CoV-2 evolution. And this is a picture that's showing the different waves. This is from nextstrain.org, which I encourage everyone to look at. And it shows the different waves of these variants over time. And when the COVID-19 vaccines were developed and tested, it was during this kind of gray period where all of the viruses were very similar to the original Omicron strain, the original Wuhan strain. But then as the vaccines were rolled out globally, we started to see Alpha and then Delta virus, and we noticed that these viruses were escaping our vaccines. And we saw a drop in effectiveness against infection, like asymptomatic infection, and also mild illness. But we had maintained really good protection against severe disease, hospitalization, and death. And that has continued to today, though I think now we see some drop off even in that level of protection if it's been several years since you got that first vaccine. Nowadays, we're dealing with Omicron, and this is the very beginning of seeing some updated boosters that include these new variants. So what about Omicron? So Omicron, it's one name. It's a name like Alpha, it's a name like Delta, but Omicron diversity really is now becoming its own pandemic. So this is a figure that's showing it's a phylogenetic tree. So it's showing the distance between each of these viruses in terms of number of mutations and mutations compared to the original strain. And I'm pointing it out here because I'm trying to show that the subvariants of Omicron, some of them are as different to the original Omicron as Omicron is from Wuhan. So we're now getting really far out, and even the Omicron variants are creating their own variants. So the response to this in the world and industry has been to try to update the vaccines, but we've really only seen this happen fully with the mRNA vaccines. And on the left is kind of all the current vaccines that are based on the ancestral or original strain. These are all the World Health Organization authorized vaccines. And then I've also added in, kind of as an example, ones that are also authorized in India, because India has a large number of kind of homegrown vaccines that are authorized for use there. But in terms of Omicron-specific vaccines, the only authorized ones currently are mRNA-based vaccines, and this is already really limited access to these updated vaccines. And the US recommended back in like November that we switch to the bivalent vaccines. And when the FDA approved these vaccines, they actually have very little data on them, just a little bit of animal data, a little bit of early clinical data. So not a lot at the time that they made the recommendation. What the recommendations are now is that everyone age 6 or older should get at least one bivalent boost. Individuals that are immunocompromised should consider getting a second bivalent boost. Kids, it kind of depends on what they got before. And importantly, the monovalent mRNA vaccines are no longer recommended, and some of them actually aren't even authorized. So this is a real change. The US and other countries have followed in terms of updating their vaccines. So the summary for this part is that 13 billion COVID-19 vaccines have been administered in the last 3 years. The vaccine type varies greatly around the world. The majority of vaccines, really when you include China in the picture, has not been mRNA. These vaccines have saved over 20 million lives in just the first year. But that impact has really been the greatest in high-income countries. And there's a large fraction of the global the global population that's still unvaccinated. Apologies for the typo. In addition, now we have to respond to SARS-CoV-2 diversification and the continued evolution of Omicron. And bivalent mRNA vaccines that include Omicron strains have been designed and they've been introduced already to high and middle income countries. And the US recommendations, for example, no longer include monovalent vaccines. So what do we know about the immune responses that are generated by these vaccines? And this is a situation where the vaccines were rolled out to the general population before we had the immunogenicity data. So it's really hard to interpret this data. This is all kind of retrospective. And that bears out in some of the slides I'm going to show you where it's kind of mixed what the data looks like. And this made it hard for people to really decide if it was worth it for bivalent doses. But overall, my interpretation of the data is that there is an increase in cross-Omicron neutralization with the bivalent booster. But I'll show you how the data is mixed. So for example, in this study shows very improved cross-Omicron responses. And what that means to me is cross-Omicron meaning like all the subvariants, like XBB, which is circulating now. So participants in this study that had gotten just one monovalent boost had very poor responses against the Omicron subvariants. Those who got 2 monovalent boosts did have a significant boost in responses, even against BA.5 and a little bit against the new XBB. And then the bivalent booster put that up another notch. This study, on the other hand, showed no difference in the cross-Omicron responses between the monovalent and the bivalent. So against the original strain, which is on the left, versus BA.5, which is in the vaccine, versus some new subvariants, didn't see any statistically significant difference. This study, this comes out of our group here at Beth Israel Deaconess in Boston. And here, this is a group that got monovalent versus a group that got a bivalent boost. And the first thing I really want to show is that getting a boost, any boost, significantly increases your neutralization of the variants. So not just the original strain, but also the Omicron strains. The bivalent boost in absolute numbers was a little bit better, not tremendously better. Not the biggest difference was the fact of getting boosted at all. So I'm going to just emphasize that a couple of times. But in this case, there was a small improvement. And then this is the last one that I'm going to show. which shows improvement across Omicron responses with the bivalent, but in particular among individuals with hybrid immunity. So on the left is people who got a monovalent boost, and there they have, some BA5 responses, almost nothing against XBB. If they had the bivalent boost, which is in the middle, but had not previously been infected, they do get an improvement in their XBB responses. So that's great. But where you see a really nice expansion in the breadth is in people who've been infected before, and then they get the bivalent boost. And in that group, you see a pretty significant increase in your XBB responses, which is what's out now, with titers that are in the range that we would anticipate to be protective. So the data on our immune responses in summary here came after the bivalent vaccines were introduced into the general population. And so immunogenicity data is very hard to interpret, but both monovalent and bivalent vaccines can boost cross-Omicron responses. And bivalent vaccines appear slightly better than monovalent, particularly in the context of hybrid immunity. So now let's get to some real-world data, the vaccine effectiveness data. And I like this figure because it's kind of simple and it tells the whole story to me a little bit, where it's looking in the United States at incidence rates. So what's the incidence of COVID-19 cases and the incidence of deaths related to COVID-19? And on the left in black are people who have not been vaccinated, so unvaccinated individuals. And they have by far, even for just asymptomatic cases, any kind of case, they have the highest rate. If they've had a monovalent dose, which is the open circles in blue, they have a big reduction. And if they've had the bivalent boost, which is the closed blue circle, they have an improvement, even above what a monovalent boost will do. And then you can see it on the right side, actually a little bit more of a difference with deaths. So any vaccine is going to get you much, much lower death rates related to COVID. That's the number one lesson. And the bivalent booster, in the little breakout box, you can see it is better. It brings you almost kind of close to zero in terms of protection, in terms of your the rate of COVID-19 deaths. So effectiveness data, as I mentioned, is hard to interpret because the population now out there is just so heterogeneous. People have been infected, vaccinated, they've gotten boosters, 3 boosters, 4, all different times. So any of this data, you could unpack it in Journal Club all night and try to understand it. But the big picture that I want to show is that all of this data is showing first that boosting of any kind improves protection compared to not being vaccinated. So boosting or vaccination is all better than not being vaccinated. And this is a figure that's showing vaccine effectiveness against emergency and urgent care visits. And this is related, compared to not being vaccinated. And this is showing that the bivalent boosters are significantly increasing the vaccine effectiveness, at least for the first 2 to 3 months. And then you start to see a decline in effectiveness. And this is more pronounced in older folks. So people who are age 65 and older, then having that bivalent booster really increases your vaccine effectiveness. Similarly, same story, but against hospitalization. So getting a bivalent booster compared to being unvaccinated significantly increases your protection against hospitalization. So in Nordic countries, including 2 figures here from Denmark and Norway, they asked a very simple question, which is a very real world question. Okay, people who got 3 doses of the vaccine, and then people who got a 4th dose of what was available, which is a bivalent vaccine. Was there a difference in the incidence of COVID? And yes, there was a difference in both of these countries. In blue are the groups that just had 3 doses of a COVID vaccine. That's their cumulative incidence, compared to that kind of maroon group that got a 4th dose, in this case, of a bivalent vaccine. Now, can we say, was it just getting a 4th dose, or was it the fact that it was bivalent that really made the difference in reducing incidence? No, we really can't say based on this data. But it's also what you're faced with when you're talking to a patient, because the patient's asking you, should I get a fourth dose? And so you can say, hey, yes, it is definitely going to decrease the incidence, in this case of hospitalization. And this is a figure from Lancet that was looking at data from Israel. And they also asked this question in a very simple way. Let's compare people who got the bivalent mRNA versus people who did not. And you can dig into that and say, okay, obviously those groups of people are going to be very different along a lot of different parameters. But if you just look at that one variable, let's look at the incidence rates. And they are clearly the people who did not receive the bivalent booster had higher rates of hospitalization from COVID compared to those who did not get the booster. So that kind of helps if you're in that clinical encounter, because you can just say it very simply, like, look, there's a lot of variables here, but I can tell you the data shows that the people who get the booster do better. But for how long, and how long, and how did the boosters compare to the monovalent? I mean, this is the question kind of the day, because it matters for designing the next vaccine. Does it matter to update these vaccines? And it's really hard to know based on just the way the vaccines were rolled out. So everything changes over time, and these monovalent versus bivalent rolled out at different times. So nevertheless, you can try to look at this, and these folks from North Carolina did that. On the left, they're looking at vaccine effectiveness. If you got a booster before November 1st, that's when the bivalents came out, or after, over time. And what they're trying to do with these colors in the bottom is they're showing you the different waves of infection by variant. So kind of showing you that there is a mismatch between the vaccines and the variants, so that if you got boosted before, really your vaccine doesn't match at all the variants that were circulating. If you got boosted with the bivalent, you have some match for a period of time, but even then in North Carolina, if you got boosted with the BA.5 containing vaccine, for the most part, you were already being exposed to BQ1. So it was already kind of out of date by the time most people were getting this bivalent vaccine. And so the protection, either boost increased protection against Omicron, whether you got it monovalent or bivalent. And the same thing for hospitalization. Maybe a little bit better effect with the bivalent. But I point out on the right here, for protection against hospitalization, because it's kind of worrisome, the trend down and the reduction in protection, showing that, for whatever reason in this data set, this boost and increase in effectiveness really started to come down after only just a few months. And that's either something to do with mRNA durability, or something to do with the quick immune escape that we might be seeing with some of the new variants. So how does that factor into designing a new vaccine is going to be hard to say, as new variants are coming kind of faster than we can design even mRNA vaccines. So vaccine effectiveness data has continued to come out, and people have tried to look at it compared to the monovalents. This is an additional data set that compared the bivalent boost to those who got a monovalent boost. And this is in older individuals. And there is, relative vaccine effectiveness increase of 60% that wanes again. So this is similar to the North Carolina data, where you get this improvement, but it wanes over time. This is a table from a paper. These are all kind of new online papers from Japan that was looking at effectiveness against symptomatic SARS-CoV-2. And in the top part of the table is looking at the comparison if you've got the bivalent vaccine versus people who got a monovalent dose like 6 months ago, more than 6 months ago. And when you compare that, there is an increase in vaccine effectiveness compared to the monovalent. But, that's kind of unfair, right? If you get a bivalent boost today, it's probably going to give you improved responses compared to getting a monovalent 6 months ago. So when they looked at that again, and they said, well, let's compare it if you got the monovalent dose less than 3 months ago. And there they didn't see a change in vaccine effectiveness. So what they're seeing is that, a lot of the difference and improvement we might be seeing with the bivalent to some extent also reflects like how long it's been since someone got a monovalent dose. And that there's two ways to interpret that depending on your perspective. So one way is to say, oh shoot, we just went through all this trouble to design these bivalent vaccines. And now that doesn't seem to have made a huge difference compared to just getting boosted. Or you could say, hey, I don't see myself getting access to an mRNA bivalent vaccine anytime soon, and glad to hear that if I just get a monovalent dose, that could probably boost my responses as well. So vaccine effectiveness studies all point to an improvement in protection from the bivalent updated boosters and protective antibodies. But again, the data is very hard to interpret from these effectiveness studies. They have many, many caveats about all the different populations that are getting the vaccines at different times. But one of the biggest things that are not really explained or accounted for is the role of previous infection. And I didn't have time today to get into it, but certainly having immunity already from being infected, is going to blunt some of the differences that we see between these vaccines, because that also provides protection. But never forget, no matter what these studies show, the worst outcomes are always in unvaccinated persons. And our priority really should still be to get everyone a primary vaccination series. And maybe that's with a new updated vaccine or any vaccine, particularly if someone has somehow made it this far without getting infected. Those people are really at risk and should get a vaccine one way or another. Similarly, boosting with any vaccine is better than not boosting. So for those of us who have friends and family that got their primary series back in 2021, it's a couple of years later now, and boosting with anything is going to be better than not boosting. But if you have the option, the bivalent vaccines appear better than the monovalent vaccines, at least in the short term, while they're still relatively well matched to the circulating variants. So finally, in summary, COVID-19 vaccines, the primary series has saved, greater probably than 20 million lives. But protection has waned over time and against the Omicron subvariants. Bivalent vaccines have been designed that contain a combination of the Wuhan and the Omicron strains, and people continue to design newer ones with new strains. Immune responses following these bivalent vaccines show an overall improvement in cross Omicron protection, but also any booster will improve responses. And then a couple of things that I didn't get into deeply with data here is just that future vaccines will likely have to drop the original ancestral strain to avoid pumping up the immunity towards that old strain that's not around anymore. So I think you'll see that in the future, monovalent vaccines with just a current strain, or maybe bivalent with two current strains, but a dropping of that original one. And a focus on whatever the latest strains are in circulation. And then finally, ideally, because we can't seem to catch up fast enough with what's circulating, is that we should either design a vaccine that is so-called variant proof, meaning it's, focuses on a different part of the virus or is more conserved, or find a way to anticipate what future variants will be, like with, ChatGPT or our best computer modelers, to guess what the new variants are going to be before we actually see them in circulation. Okay, so thank you very much. I'll stop there and look forward to any discussion that comes up later. Thank you.